Good afternoon, everyone. This is the April 11th meeting of VCSQI's Person and Family Engagement Work Group. Today, we're going to focus on medication management, one of the 6 person and family engagement metrics. I don't believe there are any other agenda items to be added today, so we're going to go right to the first agenda item, which is a practice story presented again by Bakula Dave from Heart Care Associates in Hopewell, Virginia. Mrs. Dave, would you like to take the mic and let me know when you want me to show your document?
Yeah, you can show the document now while we start. Basically, weight management is a very sensitive issue. And also, but very important one, because once the weight management is done, or weight is properly managed, most of the problem gets resolved, health issue resolves itself. At least, they say 5% weight loss, you can start feeling the difference. But the most important is approaching, because this is a very sensitive issue. How I try is, each patient is different, but I just say, like, all these holidays been passed, like Christmas, Thanksgiving, Easter, and long cold winter we had. So I said at least 60% of our patient has gained weight from 5 to 15 pounds. And now summer is coming. So this is how I start. So patient don't feel that they are the only one. We are not targeting one person only, but it's a general. And then I also mentioned that this is one of the quality measure we have signed up with CMS. So we have a program. Would you like to join? And with together, and if there is a family member, so that's of course most welcome. So we can, try to help you lose weight. And this approach is really, really positive, and it's most, accepted with our patients. So this is how first I get them their positive, approval with the weight loss. Then we try to talk about some. First, I try to just a general conversation, that when was the lowest weight they had and the highest weight gain they had, and how in the past, if they were able to do, like, for somebody's wedding or some important event coming, they were able to lose weight. So they are very willing to say that. And there is always a one time and a point that they have lost weight sometime, some point. So then they're very eager to say that. And so that gives them some motivation. Okay, I said, now summer is coming. And at certain, like, BMI, then when I put the numbers together, put number, like, okay, your BMI is this. And, Dr. Dave has already put a stent on it, or, you have, they suffer a heart attack. So by, decreasing BMI, losing weight will help your heart. So heart has to work less, and you will have a quality life. So that also gets to that. So risk associated with that, try to get to that and get their positive, acceptance. So then, once they agree, then I try to tell them that 2 ways. One, reduce the calorie. The second, accountability, which is log everything. Log what you eat, at least for 3 days. So the patient who are more educated and they can comprehend calorie intake and all these things, then I ask them to have a calculate the calorie, and at least try to start with reducing 500 calories a day. And then, so they know, basically they have done it before. So they know, so that works good. The people who does not care about calorie or anything, they just only, and not much educated, just I talk to them, like, if you can remove a portion, 1 or 2 portion of bread, or especially the calorie drinks, the soda, and those things. So that also helps them lose, weight loss. And along with that, another important thing is I try to find out that their daily pattern of eating. And most of them don't eat. They have a 4, 5, 6 hours, 7, 8 hours of prolonged starvation, and then they hit the food and they mess up. So I said every 4 hours, even a small protein bar, yogurt container, some fruit, a vegetable. So those things help them, that, okay, they can start working. And if their caretaker or family members, they also said, okay, we both can start together. So that even much positive, because everybody needs, mostly they needed to lose weight or maintain the weight. So that helps. Then the other factors affecting, which, mostly I have tried to cover most in my assessment, but other thing is like sleeping habit. So because if they don't have a good night sleep enough, then the stress hormone acts up, and then tendency eating more sugary food, and then it becomes irregular eating habit. And so just try to control to have enough sleep, proper exercise, and then also timely eating, not random, because sometimes due to their job or their some other their lifestyle, they're not eating pattern is very irregular. So then try to help them with that. And so these are a few things it's working, and summer is coming. So BMI management, so far we are now it is such a good positive approach and motivation with all the patients, with us and our staff. So that's what I wanted to share, that this is the time, and most of them may have signed up for BMI for the quality measure. So that was the idea to start engage patient and their family, everybody, with a weight management program. And since we are approaching summer and we had a long cold winter, this will be very helpful.
Thank you so much, Mrs. Dave. And you're right, it's comforting to know I'm not the only one who put some weight on over the long, cold winter. So these are nicely spelled out, the approach that you use to try and bring a sensitive topic up with your patients, and focusing on caloric intake and accountability. The journal, I think, is a great idea. How are your patients taking this? Those that
most of them they are taking it very well, very positive. And they say, okay, next time I come, I'll have a 10 pound. I said, don't overdo it, but just, I said, have a realistic goal. But they say, okay, next visit you will see me, some weight loss, with the weight loss. And then it's just they are right now they're committed. They're very excited about it and happy about it to start something. Everybody's living with such a good feeling, they have something to do. And now in weather changing, I'm sure it will happen. They will be more, active. Another thing is a couple of patients say that after they eat, they just sit down on a sofa, watch TV or something. That's a main meal, the evening dinner. That's the one. So I said, have an early dinner, and then also don't sit right after eating. Just walk around and stay at least active for at least half an hour or so. Mm-hmm. So that might otherwise if they sit and right after eating watch TV, and basically they don't eat very well during the daytime, and then dinner is the most it shouldn't be, but for the most of the patient, their dinner was the main meal.
Right.
And they were sitting right, like, watching TV or laying down after dinner, and that was
I know
that gets.
last time you mentioned that your patients often come with a caregiver or family members. Are they participating as well, are you finding?
Yes, actually, yes, they are the one who more interested, because I'm talking to the patient about this, and then I said, okay, we need your help, but they're also, oh, I will do that. We both can go out for a walk, or we both, I said, try to log everything. So some of them are making their meal, preparing meals, so that they keep this thing in their mind, like, high protein, high fiber, all these things and then avoid fast food. So they are, so this is helping, like, for both of them.
Right.
Yeah. So this is the right time, and it is a good, family and caretaker involvement with that. So we are benefiting both, of course, the patient, but then also, caretaker is also like willing to participate in the same thing, because they're listening, and they're approaching. And I said, you are also same thing, I fill out them form too, like their, goals, because we have say, okay, so what do you think, how much what are the activities you will be doing? So there is another, like we have a worksheet for that. So goal setting, and they say, because it's like personalized. So I give caretaker also one, a worksheet too, that it says like short-term goal, what I want to achieve. So they both will say, okay, maybe 5 pounds. Other one say, okay, I will do more. And then how will you achieve? And when will I aim to reach my goal? Like, if I said, if you taking 500 calorie, per day, you will see the difference in a week or two. So then your goal you can achieve, like something to look forward to. So like at 3 months or 6 months visit, when they will be here in the office, I said that, can I expect this much? And then I keep all their papers, whatever their commitment and everything, in the chart. So when they'll come, we'll go over with that. And at that time, we'll know, like, that we will have mostly, looks like, because summer is coming, mostly we'll have a success story. If some people, due to their physical condition, they cannot lose weight, then the doctor will, talk to them, and they can have that, what is other options available. But right now, we are just thinking of just approaching with a diet control, calorie intake, and some discipline.
So this is
accountability.
This is a very nice write-up that summarizes what you do. I'm wondering if you have a different document that you actually give to the patient or family member. Because this one's...
So there is I can, it's like a worksheet, like goal setting, and then like short-term goals, long-term achievement, and then which activities. See, some of them, those I ask them to mark, like, getting started, like, can you see, like, will you be able to drink 8 glasses of water? Will you make sure all 3 meals, every 4 hours eat something, or high intake in protein? So some of them they will mark. Some I have a worksheet, so maybe I can attach the worksheet with that. So they're very, like, right now they're all charged up and very happy when they leave. Even though they have gained weight, they have some intense, like, some hope that, okay, somebody's helping and something good is happening with their health.
So when did you implement this program?
Actually, like, we've been doing this BMI, but like systematic approach, we have started like last month or that, with giving them. Before I was just verbally telling. Remember when we had in the first meeting when I said, but that was more on a caregiver and a friends and family involvement, but that time also the BMI, like a weight reduction was there, like avoid fast food, eat home cooked meal, but it was just a general. But now this is like a more systematic, approach that you write down, and then, and this they're like, first one, they were not ready to commit anything in a paper. It was just a verbal that involving caregiver, telling them like a little bit more compassion, and that was working like 60-40. 60% of the caregivers were like willing, approaching and things like that. But with weight management, actually caregiver are also more interested in that. Because patient is kind of like, they have a caregiver because they are not physically totally fit, like, they cannot do whole lot of walking or they're wheelchair bound or something like that. But caregiver they can move around and this and that. They want to lose weight faster and they are more interested in that. But it's whichever way, because if they lose 5 pounds, at least patient will lose 2 to 3 pounds.
It will be interesting to see your measured results. Ivan, and you can talk about hopefully sharing a success story more broadly across the national audience. It's really nice work.
Right. So far, when they leave, they really leave with very they have a project to do. They have something fun thing to do. Because just before only the caregiving, when I was talking to them, it was compassion, it was still there. But this is like a joint activity. I have given them to do something. So
and
that
providing some written tools, I think, is always helpful for people to go back and refer to. And Ivan, do you have any thoughts? I know you've been talking with Mrs. Dave regularly. You might be on mute.
Yeah, the thoughts that come to mind would make this impactful is there's what happens in the hospital and there's what you can do in the practice setting, but you have to incorporate this into lifestyle. And we talk about, balance a lot. We talk about lifestyle a lot. And what this does, it kind of starts a conversation in the practice about how do we take these behaviors that we want to see and how do we integrate it and how do we make you aware of it so that it's top of mind, but then you sort of just integrate it into your life day by day until it becomes a habit. And that's the benefit of it long term, especially, given the population that you're serving.
Right. Okay, any other comments for Bakula? Well, thank you again so much for stepping up and sharing the great work that you're doing and being willing to share the documents as well.
Agreed.
I think you're all putting good thought into how to engage with patients. Was someone else going to say something?
I like the approach. I think it's good to make people feel like they're not alone in solving their problem, and that discussing it can help to make it more actionable.
Yes, thank you, Jana. All right. Well, Mrs. Dave, if you need to go back to your patients, we certainly understand. We're just going to talk a little bit more today about some of the medication management activities. So again, thank you, and we hope you'll be on future calls.
Thanks.
So I wanted to just show a few tools that are available and resources for medication management. This is the person and family engagement metric number 6, and all of those are still listed in Appendix B of the agenda and will remain in the minutes. There are several links there, some of which I would like to highlight. So I'm going to go down to appendix or attachment C, I think is where those all are. So these first couple little charts are just documents or charts from one of the references. Which is at the bottom here. It's from HRET, which is part of the American Hospital Association. But these are active links in here, I believe, once you get into the actual HRET link. Lots of tools that patients can use to keep track of their medications. And this was just another box with some statistics in it about how many of us are taking a prescription. 2 out of every 3 patients who visit a doctor leave with at least 1 prescription, which leads to a record volume of nearly 3.4 billion, and that's in 2005. I don't know what the current number is, but I have to guess it's higher than that. The other thing, and I don't know that that statistic is in this little box, but when you look at the reasons patients are readmitted to the hospital, if you were to have a pie chart of the various reasons, the biggest piece of that pie would be related to medication. Either they didn't take it or there was some other problem with the meds the patient was taking. So it's really very important to engage patients in conversations about their medications and assure they know what they're taking and how to take them. So this first link is a longer article that those 2 first little charts are from. This link is for an ARC tool, and this particular link just shows implementation of a, it's sort of a quick start guide. Whoops, sorry about that. And I think it's beneficial to look at and understand as it explains what medication management is and what a good strategy includes. So I'm not going to read through all of this, but it does describe and identify tools for all to use. And I think these are in the larger document that ARC has, for patients and families to use, and for clinicians and practice staff to use, as well as administrators. So this is a good resource that will take you to other resources. This particular link, Rare Readmissions, does focus on the readmission issue, readmission to the hospital, or ER visits, and you can see it's devoted a whole section on the left side here, 5 key areas to medication management. I would encourage you to look at all these links, however, especially if you're working with your inpatient services to try and reduce readmissions. But here, this is only 1 or 2 pages long, I think, if you were to print it. Talks about typical transition failures, transition meaning when the patient leaves the provider, and in this case, I think they are talking more about a hospital. But you can certainly apply some of these transition failures to the outpatient setting when the patient leaves their office visit. And the transition failures include oversight of the medication list, meaning one is not put together, the prescribed meds, perhaps not adjusted, communication, not only with the patient and caregiver, but across the continuum of care to other providers, and then lack of understanding or engagement of the patient and family. Best practices and strategies for improvement are suggested, along with 5 potential process measures you could use to determine and help you assess how well medication management with the patient is working in your practice. This next one really focuses quite a bit on assuring that the nurses in your practice or those who may be teaching medication are prepared to do so, knowing what questions to ask the patient, what observations to make. So there's some tools in here that, again, whether or not you actually implement them, just reading through the questions and thinking about, are we asking our patients these particular types of questions? Are we observing? Do we know whether or not our patients or their family members truly understand the medications they're taking and how to take them? This I think it's the 5th link. This is a real nice one-pager that talks about teaching patients about their meds. I like the way they've said at the top here, learn what to say and what never to say. So this is a very easy to read and understand quick document that will help you as a provider consider your own behaviors as it relates to teaching your patients about their medications. And many of these documents, by the way, agree that the foundation of good medication management is medication reconciliation. This is a process that was kicked off by several healthcare organizations, accreditors, improvement organizations, probably 15 years ago, that promotes or expects, depending on which organization has written their document on it, that when the patient comes to the provider, an agreed upon list of meds that the patient is currently taking is created. This is a joint effort between the provider and the patient or family member, hoping that the patient and family member actually knows all that they're taking, whether it's over-the-counter, prescribed, herbs, vitamins, because this is the list that will help you, the prescriber, understand where duplication might exist, where dangerous interactions might be happening, things that the patient is taking that perhaps you don't even know about. Once med reconciliation is achieved, and it's hard to do, but to me that's kind of underscores the reason you do it. If you don't know what your patients are taking, going through the process of reconciling as best you can will only help improve the patient's condition, because you have a chance to reevaluate those meds. And once those meds are reevaluated and the right meds and the right doses and times are reestablished for the patient, and of course this may include communicating with other prescribers if the patient sees specialists as well as primary care, but once that list is confirmed, it's really important to know that the patient or family member or caregiver understands what those meds are being prescribed for and how they are to be taken, as well as what side effects to watch for. And a common approach here that's used in hospitals, and I think increasingly in outpatient settings, is called teach back. And this is where we probably, as clinicians, first use teach back methods when asking patients or teaching patients how to maybe give their own insulin or give their own heparin if it required a sub-Q daily dose of heparin. And in this case, teaching usually involved showing the patient what to do and then watching them demonstrate it back. When it doesn't involve a skill, like giving an injection, the best way to ask the patient or understand if they understand is to share the teaching and then kind of own it's kind of a way of putting the patient at ease, but rather than saying, now tell me what you heard, or making it sound like a quiz that could be insulting to the patient, you share with them something along the lines of, I've just shared a lot of information with you about your medications. I'm not sure if I presented it all in a way you could understand. Can you share with me now what you understand about your medications? So you're kind of offering them a little bit of courtesy by maybe owning that you didn't teach it well, and that might not be true. But it's a good way to soften the request to the patient to share back what they've learned. There's 2 other links on this chart, and there's plenty written about teach back, by the way. We can help you more with that, as well as just provide more resources. This particular patient reminder app, this isn't necessarily a commercial, but it's an interesting tool that exists for people who use their phone a lot. And this is actually a video. I'll just kick it off a little bit, but this person is attesting to the fact that
I was 26, I went to bed and I had a seizure, and that led to the diagnosis of a 5-centimeter brain tumor. It's a really big deal that I'm able to talk to you because after my surgery I woke up with aphasia, which meant that I couldn't talk, and that lasted for like 2 or 3 months. Before I got sick and had a seizure, I was very type A. I like to be in control. After I was struggling with not being able to have that control, I was put on 8 different medications, multiple doses a day and half a pill a day. And so I couldn't keep track of all of that. And that fell on my soon-to-be husband.
All I had was several alarms on my phone and a note. Eventually, I did have to go back to work.
When he had to go back to work, it would be my responsibility to take those medications. And so I downloaded a few applications, and the one that I found that worked best was Medisafe. And now, like, I know when I'm supposed to take my medications, but I still have it.
Okay, I'm going to stop here. As I said, this isn't really meant to be a commercial, but just to demonstrate that there are apps now that help patients take their medications at least on time. This last link here shows several YouTube videos on a variety of medication management topics. So the only other thing I wanted to share with you is a hard copy instrument that I actually developed for my mother when she was living in assisted living and had her own meds that she managed because she was still in the independent living part of this particular facility. And so she certainly wasn't going to use a cell phone with an app at 89 years old. So I fell back on my old nursing practices from hospitals and created a medication administration record for her. And I share this with everybody I know, including all of you. It's something that's easier for elderly patients, perhaps, using a hard copy. I put little signals on it, you know, sunshine was morning. At one point, she was also taking something at lunch, so I had a clock icon with, you know, focused on 12 noon, dinner, and nighttime. And I did my best to try and keep this to 1 page. These are not all her meds at the time, by the way. I played with this, so to demonstrate some key points, like sometimes I came to find that I really needed to highlight how many pills she was taking at that time. And in the case of Coumadin, sometimes the dose varies by day. Sometimes the med doesn't come in the dose that needs to be taken. And so I refined this over the few years that she used it to keep up with what she needed as a reminder. So again, I just offer it as a sample. I found that putting medical record number on here was helpful if getting on the phone was important, and you know the provider would ask for a medical record number. So you can customize this as it pertains to the patient or your practice. So just wanted to share a few things. I was hoping we'd have a few more people on the call today to share what they're doing about medication management, but we'll pick up on this again in a future call, and I'll ask you to just email me. Hopefully people will be listening to this recording and talk with Ivan about it on your calls. You can contact me directly, and we'll get more conversation going on self-medication management. Our next call is scheduled, reminder to please complete the PFE survey. The link is there in the agenda, and we'll continue in the minutes. And again, lots of resources on the Healthcare Community website. So our next call is scheduled for May 2nd from 1 to 2 p.m. Eastern Time, hoping to have a speaker to discuss motivational interviewing, which is closely tied, as the agenda says here, to shared decision-making and other types of patient and family engagement. Any comments any of my colleagues would like to make before we sign off?
Presentation, Debbie.
All right. Thanks, everyone, and have a good week. Bye-bye.